Hello guys. Welcome to MedSense, where medicine makes sense. In today's video we will be talking about Down syndrome, to get you from zero to hero. Stay focused and let's enjoy the ride. What is Down syndrome? Down syndrome is a condition where a person is born with an extra chromosome 21. Normally, we have 46 chromosomes formed in 23 pairs. But people with Down syndrome have 47 chromosomes, because there's one extra copy of chromosome 21. As you see on this image to the right, there is an extra chromosome at the 21 site which makes them 3 instead of 2, and that is why it is called trisomy, which means 3 chromosomes. But why does it happen? It usually occurs by chance during formation of the egg or sperm, usually when the egg or sperm cell divides and the chromosome doesn't separate properly. The exact reason isn't always known, but the risk increases with the mother's age, especially after 35 years of age. The karyotype for them is found to be as following. The male has a 47XY plus 21 while the female has a 47XX plus 21. As you see to right, the upper picture representing a male with Down syndrome while below is a female with Down syndrome. Now, let's talk about incidence. The incidence rates are as following. Overall it affects 1 in every 700 live births, but risk rises with maternal age, as the researches showed that in the age of 20, it affects 1 in 2,000 live births, while at the age of 35, it affects 1 in 350 live births, while after the age of 45, it affects 1 in 25 live births. So put in your mind that Down syndrome is the most common chromosomal abnormalities. Now, how does this happen? The genetic mechanism of its occurrence is one of the following 3. Number 1 is Meiotic nondisjunction, which accounts for approximately 90% of the cases and is often due to increased maternal age. In this case, one gamete gets 2 copies of chromosome 21, trisomy 21, while another gets none. As a result of this, all of the cells will have an extra copy of chromosome 21, as you see in this picture right here. Number 2 is translocation, also known as Robertsonian Translocation, as it was discovered by the cytogeneticist William Rees Brebner Robertson. In this condition, there is a structural rearrangement in which the long arm of chromosome 21 becomes attached, or we can say translocated, to another acrocentric chromosome, most commonly chromosome 14. You can see in this picture that the extra copy is attached to another chromosome, which is 14. The third and last one is Mosaicism, which is described as the presence of 2 or more genetically different cell lines in the same individual, resulting from mitotic nondisjunction after fertilization. You see in this picture that some cells are normal and some of them are trisomic, resulting in a milder phenotype. Now let's discuss what are the physical characteristics of someone with Down syndrome. I remind you this is an important part for you exams as a medical student, as you get questioned about it a lot, so you need to know them very well. So we could remember it, we need to start from the head to toe. When you look at the head shape of a patient with Down syndrome, we notice that they have a flat occiput and facial profile, also known as brachycephaly, and you notice it more when you look from the sides. This is a picture shows what normal head looks like and what brachycephaly head looks like. Next, when you look at their face, you'll notice a flat nasal bridge. This is visible when you look at the area between the eyes, as you can see in this picture. Look at the eyes, they have upward slanting palpebral fissures, meaning the openings between the eyelids are directed upward. They also have what's called an epicanthal fold, which is described as a fold of skin on the upper eyelid that covers the inner corner of the eye. Here is a closer picture showing the epicanthal folds. The last feature of the eyes is brush-filled spots, which are small, white spots arranged in a ring shape around the iris. This is a picture showing brush-filled spots in a child with Down syndrome. When you look at the mouth, you will see a small jaw, which can lead to an open mouth with a protruding tongue. When you look at the ears, they might be small, though sometimes they are normal in size. We have finished with the head and face, and now we are going down to the neck. On the neck, there is often excess skin at the nape, as we can see in this picture. Let's go down to the hands. First, they have short, broad hands. Second, they have clinodactyly of the small finger, which is an inward curvature. The last feature is a single palmar crease, also called a simian crease, as you can see in this picture. This is another picture showing what a normal crease looks like compared to the simian crease. The last physical feature is in the feet. They have a wide gap between the first and second toes as a result of the medial displacement of the great toe. This is simply a large space between the first and second toe, also called a sandal gap. Now let's talk about the associated congenital and medical problems. The systemic manifestations are as follows. Starting with the cardiovascular system, they can have congenital heart defects. These often include endocardial cushion defects and atrioventricular septal defects. Next are the gastrointestinal manifestations. These include duodenal atresia. In this condition, a newborn baby presents with bilious vomiting that appears on the first day of life. If you take an X-ray of the abdomen, it shows a characteristic sign called the double bubble sign. They may also have Hirschsprung's disease. This is a condition where nerve cells are missing in a part of the large intestine, which results in a bowel blockage. Moving to the central nervous system, manifestations include hypotonia, which is low muscle tone, and intellectual disability in most cases. From a hematological perspective, there is an increased risk of developing leukemia, specifically acute lymphoblastic leukemia and also acute megakaryoblast leukemia. Regarding the reproductive system, they might experience infertility. This is a difficulty in conceiving or carrying a pregnancy to term, and it may be treatable. Alternatively, they might have sterility, which is the irreversible inability to conceive. In simple terms, this means they will not be able to have children at all. Finally, do not forget to mention that overall, these individuals have a high tendency to develop secondary and recurrent infections. Okay, now let's smoothly dive deeper into how we can diagnose Down syndrome. The diagnosis can begin during the prenatal phase, in both the first and second trimesters. In the first trimester, between weeks 11 and 14 of pregnancy, one diagnostic method is an ultrasound. This is used to measure the nuchal translucency. This is basically the measurement of the fluid-filled space at the back of the fetus's neck. If this measurement is 3 mm or more, it increases the risk of the baby having Down syndrome. An increased nuchal translucency measurement is used alongside other markers for further assessment. These include increased beta-HCG levels and decreased levels of a substance called pregnancy-associated plasma protein A. These tests together help screen for the possibility of Down syndrome. In the second trimester, which is between weeks 14 and 20, we perform what is called the quadruple marker test. This is a blood test done in the second trimester of pregnancy to estimate the risk of Down syndrome and other certain birth defects. It works by measuring 4 substances in the mother's blood. These are alpha-fetoprotein, also known as AFP, human chorionic gonadotropin or HCG, estriol, and inhibin A. The results are not a definitive diagnosis, but they help determine if further testing is needed. In cases of Down syndrome, the test typically shows a decrease in both AFP and estriol levels. Conversely, there is an increase in the levels of beta-HCG and inhibin A. So, what is the definitive diagnosis? The definitive diagnosis is achieved through a karyotype test. This requires a sample obtained through a procedure like chorionic villus sampling, which is usually done between weeks 10 and 13, or by amniocentesis, which is performed between weeks 15 and 18. For postnatal diagnosis, it is as we talked about earlier. It involves checking the characteristic physical features and then confirming the diagnosis with a karyotype test. How do we manage conditions associated with Down syndrome? This is very important, and management involves a multidisciplinary team approach. This includes providing early physiotherapy and speech therapy. The second part of management is regular screening for congenital abnormalities, such as cardiac defects and gastrointestinal abnormalities. Finally, one of the most important aspects is strong family support and counseling. We have reached the end of our journey. I hope you have enjoyed it. If you liked this video and found it helpful, please hit the like button, subscribe to our channel, and share this video with others. By doing so, you help us continue making content and to develop more and more. Thank you for watching. We will see you next time in another journey with MedSense, where medicine makes sense.